Welcome to the Osteoarthritis Action Alliance Lunch and Learn for April 2016. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today. I am pleased to introduce our presenter, Dr. Joanne Kemp. Dr. Kemp is a research fellow at the Australian Centre for Research into Injury in Sport and its Prevention, or ACRISP, at Federation University in Australia. Dr. Kemp's research is focused on hip pain and pathology in young and middle-aged adults, especially femoroacetabular impingement and associated pathology, and its impact on activity, function, and quality of life. She has a particular focus on both surgical and non-surgical interventions that can optimize outcomes in people with hip pathology and potentially slow the progression of hip disease. She's also interested in the long-term implications of sports injury on joint health, particularly the burden of osteoarthritis. Today, she will speak about femoroacetabular impingement, what is best practice physical therapy. Welcome, Dr. Kemp.
Thank you, Kirsten, and thanks very much for the invitation to speak to you all today. So today what I'm going to talk about is femoroacetabular impingement and what we consider at the moment to be best practice physical therapy. But what I'd like you to do is when you think about people who have femoroacetabular impingement, or FAI, is that these are actually young people with old hips. So I think the first question that we need to address is, why do we consider patients with FAI to be young people with old hips? If you think about the timeline of the lifespan of a patient who presents to our practice with hip pain, what we know already is that patients who have CAM-type FAI are more likely, up to 10 times more likely to end up with end-stage hip osteoarthritis within 5 to 20 years compared to those without CAM-type FAI. So what does the size of the CAM lesion measured by the alpha angle in FAI mean? So when we think about FAI, what we're looking at is a CAM lesion, which is extra bone that forms at the junction between the head and the neck of the femur, and we measure that through an X-ray measure called the alpha angle. So what that means is if the alpha angle is greater than 60 degrees, we consider that someone has a CAM lesion. If the alpha angle is greater than 78, we consider that to be a pathological CAM deformity that has that strong association with end-stage hip OA. And for patients who have a large alpha angle greater than 83, they are almost 10 times more likely to end up with end-stage hip OA within 5 years. And for every degree increase in alpha angle, there's an increased risk of end-stage OA by 5%. So essentially, people who have larger alpha angles or a larger CAM-type FAI have a greater risk of hip OA. So coming back to that timeline that we just mentioned, as we said, people with CAM FAI are more likely to end up with end-stage hip OA. What we typically see in our clinical practice is a young athlete in their teenage years presenting with hip pain. They may then become the more mature athlete in their late teens and early 20s who still can present with hip and groin pain. We then see patients who are perhaps in their late 20s and early 30s who present with hip pain. And finally, we see the more mature athlete, and that is our former Prime Minister of Australia running there, who presents with more developed hip pain and hip osteoarthritis. So what we know from the literature is that CAM lesion tends to develop in this young teenage athlete between the ages of 13 and 15 years. That by the time the patients are in their late teens and early 20s, studies have shown that these are the patients who have painful FAI and labral pathology. The athletes in their 30s are the patients who present with painful FAI, labral pathology, and we're starting to see fairly significant changes to the chondral surfaces within the hip. And finally, these more mature athletes over the age of 40 are those who present with clinical hip osteoarthritis. And looking at that timeline, what we see is that from that second time point onwards, these patients typically present with pain, poor patient-reported outcomes, and physical impairments that are very similar all the way through that timeline of progression. So what are the possible mechanisms for this, what appears to be sort of timeline of cascading degeneration within the hip joint? What may happen is because of the change in the shape of the hip that you see with CAM FAI, you get alteration in hip joint loads. Now what this can do is possibly lead to shearing within the articular cartilage. This can lead to an alteration of the extracellular matrix of the articular cartilage. And finally, you get a breakdown of the integrity of the whole chondral surface. And this can result in hip osteoarthritis. So, in summary, the typical type of patient that we see presenting with FAI has the cam lesion, as seen here on the junction between the head and the neck of the femur, and they progress to the patient with labral pathology and ultimately the patient with chondropathy. So this hopefully gives you an understanding that these patients, young patients with FAI, actually are young patients who present with quite significant degeneration in their hip joint at quite a young age. So if we're thinking about these typical patients and the type of rehabilitation that we should be giving them, it's possible that by targeting or altering the loads within the joint, we may actually be able to alter the symptoms and pain associated with that degenerative hip joint disease. And there are actually several factors that do have the potential to impact on loads within the hip joint. So if we think about hip joint stress or hip joint loading, what we know is that there are extrinsic factors that have the potential to alter or affect these loads. And these can include the type of activity that a person is doing, the amount of activity that they're doing, and their body mass. And there are also intrinsic factors that can affect their loading. So this can include the morphology of the hip that we've just talked about now. So things like FAI, hip dysplasia, labral pathology, and chondral pathology. But it can also include their hip muscle strength or their hip joint range of motion, the way that they walk and the way that they move. And these things can be affected by a person's age and also by their sex. And so we know that it's actually a good thing to have some loading and stress through the joint, because what that does is it causes reversible changes within the joint that are needed to keep the joint healthy and strong. But what can happen is if the threshold is crossed, you start to get irreversible joint damage, and this can lead to the early hip osteoarthritis that we just talked about and ultimately advanced hip OA. And it's at this stage that patients present with pain and reduced function. And so what we're trying to do with our treatment is to not cross that threshold. And so don't take patients into that stage where the loading has resulted in irreversible joint changes. So now that we have a little bit of an understanding of the type of factors that might influence loading within the joint, what I'd like to do now is to talk about the evidence that we have already for both non-surgical management, physiotherapy or physical therapy management of these patients, but also post-surgical management. And it's very important to talk about the post-surgical management because a large number and an increasingly large number of these patients are undergoing arthroscopic hip surgery for their FAI. So what evidence do we have at the moment? Well, we have very little, almost no full-scale RCT evidence that supports physical therapy management for FAI and the associated pathologies of labral pathology and chondral pathology. So the best evidence that we have to date are studies that describe impairments in FAI and impairments in people after hip arthroscopy for FAI. So let's have a look at the evidence for non-surgical management first of all. So this systematic review was conducted a couple of years ago now, where they looked at the types of non-operative treatment recommended for FAI. And there were very, very few studies, and the studies were of very poor quality. But common themes that emerged in the studies that had reported non-surgical treatment for FAI included activity modification, physical therapy, so that was just a very general umbrella term for physical therapy, a stage-based exercise approach, and retraining of the core hip musculatures, as well as education and advice. So what are the impairments that are typically seen in FAI in patients who haven't undergone surgery? And this systematic review was published by some colleagues of me here in Australia in the British Journal of Sports Medicine. And they looked at physical impairments and activity limitations in people with FAI and conducted a systematic review. And what they found in this particular review was that there were 16 studies that had looked at impairments in FAI, and these were cross-sectional and case series studies only. Typically, range of motion was reduced in all planes, but particularly in internal rotation and flexion. That hip muscle strength was reduced in all planes of movement, but particularly adduction, abduction, and extension. There was very little evidence for the motor control. When they looked at functional performance, the only thing that they found was that patients presented with a reduced depth of squat, and that gait changes showed reduced range of motion in both the sagittal and frontal planes, and reduced peak flexion, extension, adduction, external rotation, and internal rotation. So what happens to patients who have pain on one side? Do these impairments remain on one side, or is there a crossover effect where they also develop impairments in the unaffected side? And this was a study that was published by Marcy Harris-Hayes, and what she found was that in young patients with chronic hip pain, they had weakness in all of the hip muscles on the affected side, but very interestingly, on their non-painful side, they also had weakness in their hip abductors and hip external rotators. What about the trunk muscles? It's really important to consider trunk muscle impairment because the trunk controls the pelvis, and the acetabulum, or half of the hip joint, is contained within the pelvis. So whatever's happening to the pelvis, it would make logical sense that that's also having an impact on the hip joint. And this was a study published by some American researchers who looked at the effect of changes in pelvic position on impingement in patients with FAI. And what they found was that in patients who had an increased anterior pelvic tilt, so that's something that you would consider to occur when trunk muscle control is poor, there was an increase in the acetabular retroversion and also a reduction in hip internal rotation range of motion and flexion adduction internal rotation range of motion. And so they concluded from their study that trunk control can actually alter the impingement that you see in patients with FAI. In a study that we did, we also found that patients who had impingement pathology had reduced performance in the side bridge test, seen here, compared to healthy controls on both their surgical and their non-surgical or unaffected side, and that better performance in the side bridge or better trunk muscle strength predicted much higher or better outcome scores in this particular patient group. So what we can conclude from this is that it appears that trunk control can alter impingement, and that people with impingement pathology have reduced trunk control bilaterally. So we would assume that improving trunk muscle control is probably an important target in our rehab programs for patients with FAI. So what do we know then about impairments that are seen in people after they've had hip arthroscopy surgery for FAI? And we published this study looking at hip joint range of motion and hip muscle strength in people who were 12 to 24 months post-hip arthroscopy for FAI. And we compared them to healthy controls. And what we found is that patients with more significant impingement pathology had reduced internal rotation range compared to controls, but patients without significant pathology were the same as healthy controls. For hip muscle strength, we found that those people with more significant impingement pathology had reduced strength in pretty much all of their hip muscles compared to controls, but patients without significant pathology were only reduced in their hip adduction strength compared to controls. Interestingly, we found the effect was greater in women, where women had reduced strength in their abduction, adduction, and external rotation compared to men. And we found an interaction effect for both the significance of pathology and gender for hip abduction strength. So women who had more significant pathology were weaker in their hip abductors compared to men with significant pathology, and also women without pathology. So there did seem to be an interaction between your sex and the severity of pathology as to the level of impairment that you were experiencing. Excuse me. So now that we know what physical impairments predict outcomes in people with impairment or chondrolabral pathology, now that we know what impairments they have, we need to have an understanding of whether these impairments are related to the outcomes that people have. And so this was a study where we wanted to see whether or not physical impairments in that same post-op patient group predicted outcomes, quality of life outcomes in those patients. And so what we found was that a greater hip flexion range was associated with better quality of life outcomes in patients, and that greater hip adduction strength was also associated with better quality of life outcomes in patients post-hip arthroscopy for impingement-related pathology. we were able to determine the limit value for hip flexion as being 100 degrees, so that patients who had range of motion of greater than 100 degrees of flexion were more likely to have much better outcomes than those who didn't. And for hip adduction strength, we found a limit value of 0.86 Newton meters a kilo. So these things may provide therapists with targets to work towards in these patients. So what about patients' balance and their ability to perform functional tasks? And with this particular study, what we wanted to look at was the dynamic single leg balance of these young patients with hip pain. So we asked these patients to do a dynamic single leg squat, and we looked at their balance performance in this task. And what we found is that the patients with more severe impingement related pathology did have poor balance compared to controls. So they had greater excursion of the centre of pressure mediolaterally, and also a greater standard deviation in the AP plane compared to controls during the single leg task. So already in these young people, they were showing impairments in their balance during a dynamic single leg task. We then wanted to also look at the mechanics around the hip during a dynamic single leg squat. And so what we did is we asked patients to undergo the task that you can see here, and we measured their frontal plane projection angles. And what we found is that in the patients who had undergone hip arthroscopy for impingement-related pathologies, that compared to controls, they had greater hip adduction and greater knee valgus. And so this is important because this is placing patients into that typical hip impingement position. And on their operated side, they had a greater pelvic drop during the single leg stance task compared to the non-operated side. So this was again placing their hip into a greater position of impingement. And so from this study, what we found is that 1 to 2 years after hip arthroscopy, there were deficits in single leg squat performance, and that the type of positions that these patients were going into may actually increase their hip joint impingement and therefore possibly perpetuate their post-operative symptoms. So to summarise overall our evidence for both non-surgical and post-surgical impairments in patients with FAI, we found that patients with FAI are impaired, we know that patients with FAI are impaired preoperatively and non-operatively and remain impaired post-operatively compared to healthy controls. And that these impairments include reduced range of motion, specifically in flexion and internal rotation, reduced hip muscle strength, but this does appear to be sex-specific, reduced functional task performance, increased impingement in single leg squat, reduced trunk muscle function, reduced dynamic balance, and alterations in gait. So if you think about these impairments, they do sound similar to the type of impairments that we see in people with more advanced hip osteoarthritis. So as I said earlier, there's minimal full-scale RCT evidence supporting physical therapy management for FAI and associated pathology. But we now are starting to see some preliminary pilot RCT evidence to support what we do as physical therapists. So now that we have an understanding of impairments, what is the evidence for our treatment? And this was a study published by Alexis Wright and her colleagues in the States, and she conducted a pilot RCT looking at non-operative management for FAI. So she recruited 15 patients who had symptomatic FAI, diagnosed radiographically and clinically. And these 15 patients were allocated to one of 2 6-week physical therapy interventions. So group 1 underwent manual therapy, supervised exercise and advice. And group 2 received advice and a home exercise program that was unsupervised. And what she found is the between group differences for change in pain and also hip function were not statistically significant. But both groups improved around about 18 millimetres on the VAS for pain. And so this is promising evidence, preliminary evidence, that non-surgical or physical therapy management of FAI might be effective. And we've conducted a similar study looking at the efficacy of post-operative physiotherapy for FAI. So for our pilot study, our primary outcome was the feasibility of a full-scale trial, but our secondary outcome was to look at pain and function in a similar fashion to the way that Alexis Wright and her colleagues did. So for our study, we had 10 people who were allocated to a semi-standardised physiotherapy intervention where they had 8 treatments over 12 weeks, and they were given manual therapy targeted to improve range of motion, hip muscle strengthening, trunk muscle strengthening, function and balance exercises, and advice and education. Our control group, in which there were 7 people, was an education control, where their treatment frequency was the same as the physio group. So both groups turned up for 30 minutes of treatment 8 times over the 12 weeks, and they were given advice for pain management, advice for general exercise, and advice regarding weight management. And what we found for our secondary outcome, which was pain and function, was that all patient-reported outcomes improved in the physiotherapy intervention group, and the difference in the change score always favoured the physiotherapy group over the control group. But none of our changes were statistically significant due to the small numbers that we included in the pilot study. So again, this provides some preliminary evidence that a semi-standardised physiotherapy treatment regime may improve pain and function in people post-hip arthroscopy for FAI. So now that we know all these things, what should a physical therapy program for FAI include? So if we think back to the start of our talk where we talked about the loading within the hip joint, our goal of treatment should be to optimise loads within the hip. And so given what we know now, a program should include hip muscle strengthening, trunk muscle strengthening, functional and balance retraining, sport-specific retraining, range of motion optimisation and education. So let's look at each of these factors individually. Hip muscle strength. All patients do need strength in all hip muscles. However, we can be a little bit more specific than that. So if we think about the different planes of motion, it appears that hip adduction strength is important for all patients, regardless of the severity of their pathology. Hip abduction strength does appear to be important for both men and women, but particularly those who have pathology. Whereas when we consider flexion, extension and external rotation strength, this is important, but it's particularly important for women and women who have significant pathology in their hips. So what about trunk muscle strength? Well, if we think about progressively strengthening the trunk muscles, we need to consider that we want to retrain both sides because these patients have impairments on both sides of their trunk. And it's really important that we watch overactivity in hip flexor muscles, so trying to avoid things like crunches and sit-ups with a focus on trunk endurance. For our function and balance training, we need to again progressively improve people's functional and balance retraining. We need to retrain both sides because patients do have functional impairments on both sides, and it needs to be specific to their sport. We need to focus on strength and endurance, and it's really important with these patients that we follow them until they can undertake a full functional load in a safe and pain-free fashion. Sport-specific training and optimising range of motion. When we're looking at optimising range of motion, it's really important that we optimise flexion range of motion because that's the movement that is most closely associated with better outcomes. And as PTs, we have a number of different techniques we can use, such as soft tissue techniques, manual therapy techniques, muscle activation techniques, and techniques for the lumbar spine and pelvis. But rather than talking about specific techniques, the thing that I would really like to make clear is that it's very important to respect any pain that they have during these techniques because their flexion limitation may actually be protective and stopping them from taking their hips into an extreme impingement position. And finally, if we consider education, what should we be looking at? So these are the things that I think are really important in these patients, that we should be looking at their position of impingement, managing their loads, making sure that they are very aware of their pathology and prognosis, and discussing appropriate treatment options based on the evidence that we have. So if we think about the position of impingement, the position of impingement that these patients find provocative is usually a flexed and adducted and internally rotated position. Now, we're really good at looking at what they're doing in their sports, but I think it's also very important to consider their activities of daily living, that these patients may well sit for 8 or 10 hours a day in a flexed position with their legs crossed. So they're spending 90% of their time in a position of impingement during their ADLs. If we can modify their position of impingement during their ADLs, their hip may well be able to cope with some impingement, during their sporting activity. So what I'd like to say is that I think it's actually more important to look at activities and position modifications during ADL, as that cumulative load of impingement may well be able to be effectively reduced. What about their pathology and their prognosis? Well, I think it's reasonable to assume that a portion of patients who have symptomatic FAI may already have early hip osteoarthritis or those early degenerative changes to the labrum and the cartilage, so we need to treat them accordingly. We need to advise them to lose weight if that's something that they need to do. They need to keep a general level of cardiovascular fitness through a sport that they love and that's also safe for them to do. So that can be things like cycling, it can be things like a modified running program, swimming, dancing, skating, as long as it's something that they enjoy and so that they'll continue to do for a long time, and that they also are safe to do in terms of that load and position of impingement. It's very important that these patients understand it's normal to have a flare-up of symptoms, that they are living with a degenerative condition that won't go away, and so not to catastrophize or panic when they get a flare-up of symptoms, that it's manageable. They need to be prepared for an ongoing maintenance forever type exercise program that includes those things that we've talked about, so hip muscle strength, balance and neuromotor control. And importantly, these patients need to understand that we will probably be able to improve their pain and function, but they will not return to be the same as a healthy age-matched control in terms of their pain levels and their functional performance. So our final slide, our take-home message on physical therapy for FAI. Our treatment goal is to optimise hip loads using our current knowledge of impairments. We need to remember that physical impairments do exist non-operatively, pre-operatively, and remain in people post-operatively for at least 12 months. At the moment, rehab protocols tend to follow people for up to 4 months, but if these patients are impaired at least 12 months and possibly with a degenerative condition, we probably need to follow them for longer periods of time. Our rehab programs should include range of motion optimisation, strength, balance and functional training for at least 12 months, and they should be tailored to the patient's sex and their pathology if we're going to optimise outcomes. That our large full-scale RCT level 1 evidence for physical therapy management is lacking, and we do need these full-scale randomised control trials. And thank you very much for your time.
Thank you, Dr. Kemp. It's all very interesting, and I was thinking as you were talking through your presentation, you come to this last slide about the inadequacy of current physical therapy programs and protocols that typically people follow. And I was thinking about that in terms of, how long or how much improvement, do people need to keep up with their program for much longer than a typical physical therapy session would go. I assume this is another of so many scenarios where you pretty much have to keep moving for life, otherwise your symptoms just continue to degenerate.
That's right, and that's I didn't talk about this in this presentation due to lack of time, but some of the studies that we've done on patient-reported outcomes in these patient groups show that these patients, whilst they do improve with PT and they may improve with surgery as well, the level of improvement is really limited and they are significantly impaired compared to a healthy control and remain that way. So we think we're going to find in our studies as we go forward that that ongoing maintenance treatment forever is really, really important, because in a similar fashion to people who have knee osteoarthritis or may have undergone an ACL reconstruction for an ACL tear, or people with more advanced hip osteoarthritis, we know that ongoing exercise therapy is one of the few effective tools that we have in its management.
Well, in one of our working groups here at the Osteoarthritis Action Alliance, our Group 5, which is focused on OA prevention, really looks at the young athletes right at the moment. I mean, there's so many directions you can take with injury prevention, but we are focused right now on young athletes and considering their ways to prevent lower limb injury, and certainly now, obviously, hip strength and health is also very important. And just thinking about how early in people's lives they can start to show symptoms of impingement or early osteoarthritis, and that's something that we are keenly aware of and trying to address.
And that's fantastic. And I think that's really the key. I was speaking to a colleague after the recent Aussie conference, and we both agreed that, you know, once people are at that really advanced stage of osteoarthritis, it appears as though most of the things that we're trying to offer these patients are ineffective because the disease has progressed so far. And possibly what we should be doing is doing exactly what you're doing there, which is looking at preventing the factors that might contribute to the development of osteoarthritis in the first place, so injury prevention programs and those sorts of things. And then if patients have started down that degenerative path of osteoarthritis, that we should be targeting our interventions right back when they're young, before the disease has progressed. Because from the studies that we've done, we see patients who are 18, 19, 20 years old who have really significant degenerative changes in their hips already. And so this is the time point where I think we'll find in the future that our interventions will be most effective.
Right, yeah, and to spend your whole life essentially with joint pain, that is not fun at all. And you're right, we are trying to get people to pay attention early on and to prevent things from happening and to train properly. In fact, we have a working group who is currently working on exactly this thing, you know, kind of coalescing what exists out there right now with training programs for youth athletes and training, getting coaches and athletes to adopt best practices for training to strengthen joints and to move and to cut and jump and run in ways that minimize the chances for injury. So
that's fantastic.
That's the way to go.
Yeah, definitely.
All right, well, thank you very much. I greatly appreciate your spending the time with us and sharing. We have a lot of physical therapists and athletic trainers and other folks who see patients who have these issues. So it's really, I think, important to know what the latest understanding is and to be able to help them help their patients. So thank you very much.
Thanks for the invitation and thanks for having me.